the EMT said, well, what was he doing? Up there to change a light bulb or something? Why is he naked? Well, she finally told the story. They were having their afternoon delight in bed. She was tied to the bed. He stood up on the footboard to jump on top of her, and he had a cape on, and he jumped up and hit his head on the fan. Knocked him out cold, big cut. She can't get out of the bed because she's tied to it. She's screaming. The windows are open. The neighbor's outside trimming his bushes, and he hears her screaming, and she's wondering, what the hell is going on? So he goes over, and he whatever her name was, it's Abby, are you okay? No, you have to come up here. Tom fell and hit his head, and he's unconscious. So he goes inside, not expecting to see any of this. He goes inside, I'm up here. So he goes upstairs, and he walks into the bedroom, and she's naked, tied to the bed. You got to untie me. And he looks at her and says, what the hell's going on up here? She tells him the story. The guy's unconscious on the floor. They call EMS. The volunteers come. They pick him up. They put him on the stretcher. By now, he's arousable and awake enough that he can answer some questions. He's got a big gash on his head. She's dressed. The neighbor's like red. And the EMTs ask her what happened, and that's the story. Okay. How did he break his leg? Well, we dropped the stretcher. I told you he dropped it coming down the stairs. I said, well, you guys are huge. How could you drop this stretcher? This man's not that big. No, Doc, you don't understand. We left the door open because, we didn't realize what was going on. So we came into the house and nobody closed the door, and we were coming down the stairs, and there was a snake at the bottom of the step. And I saw the snake, and he was coiled up, and I didn't know what it was. I thought it happened to be it wasn't a rattlesnake, it was a corn snake. He said, and it scared me, and it startled me, and I dropped the stretcher. And the other guy at the top couldn't hold it, and he flipped it over, and the guy fell over the railing. I said, okay. Yeah, that became a messy day. So, no, they took the cape off and wrapped him in a sheet. So, I mean, there's some really crazy stuff that goes on. So, no, he needed testosterone. He was over 70. So what I'm saying is that a lot of the times, people don't know the snake, so they want to bring them in. Just don't touch the snake, because, there have been cases reported where people have touched these snakes that are allegedly dead, and because of this reflex they have like sharks, they bit them. So don't touch the snake, because you can get bitten even though you think it's dead. No, because the only thing you would need to know, is it a coral snake or is it a pit viper? Which pit vipers include rattlesnakes, pygmy rattlers, copperheads, water moccasins. Those are all pit vipers. So that's all you need to know. I mean, what would be better if you wanted to cut the head off? The problem is you don't want to touch it because of that neurologic reflex they have. Pit vipers, and realize this is all true of pit vipers. Yeah, big machetes. So pit vipers are going to have a triangular shaped head. Not real good, and they have two pits over here. So it's going to be sort of like a triangle. Just think of their heads going to be shaped like a triangle with two pits on it. Okay, a snake that has a rounded head is not going to be poisonous, except for a coral snake, which has a rounded head, a little mouth, and it's got teeth in it that look like regular teeth. It doesn't have fangs. Okay, so they look like regular teeth. And they have to inject you, coral snakes, by chewing on you. They can't just bite you and pull away. They have to chew on you because their venom works differently. And it doesn't get injected the same way as a rattlesnake's venom. So just remember that. If it's a triangular head, it's a pit viper. There is no non-poisonous snake that has a triangular head that isn't a pit viper. So remember that. Clean the wound, put them on a monitor, immobilize the extremity. You don't need to cut holes and suck out the poison. You don't need to put a tourniquet on it, not going to help. And get them to the hospital. Here's some examples. I don't know if you can see their heads that easy on these views. You see the rattlesnakes rattle, but I don't really see its head. It's supposed to be, I think, up on the right. Yeah, that one you can see there. That's not a rattlesnake. I think it's a water moccasin. this one over here. That's a rat. Oh, there's a head right here. Can you see it? You see how it looks sort of triangular? Like they have these big jaw muscles, which they do here. And then you have this snake at the bottom, which I think is one of the constrictor type snakes. I don't know which it's from, but if you look at its head is small and round, and if you look at its body, those markings are usually of a constrictor. I think that's what that is. Now, there's a timber rattler that looks similar to that. We don't have them down here. That's up in New Jersey, in the Northeast. We have coral snakes. You notice the head is round. You see the head on this snake? The head's over here. What's that? Red and yellow will kill a fellow? Yeah. Just don't get bitten. Okay, so coral snakes, which we know we do have here. Notice that these are really neurologic. These symptoms, they have a neurotoxic venom. Now, all the snakes do have some degree of neurotoxicity with their venom. Some of them also have a lot of local, what's the word I want to use? Not just neurotoxic, but tissue toxic, and it causes necrosis of the tissue to help dissolve the organism that they're trying to eat. I have had maybe 2 coral snake bites in 30 years here. What is interesting, in almost every single bite that I've seen in the ER, and I've seen maybe 2 or 3 dozen over 37 years, I don't have one that I can tell you was done inadvertently while walking through the woods. Almost everyone was drunk, thought they were faster than that rattlesnake, or that they could avoid the coral snake that was in their terrarium. Because these are all people that had these animals in their house. I mean, these were pets, quote unquote. And they all come in after an envenomation, but they didn't come right in afterwards. Some of them came in 2 and 3 and 4 hours later. So by that time, the extremity was black. Oh, I didn't think it was serious. How much have you had to drink? Oh, I only had 2 cases of beer. Yeah. Well, you all know the adage, if they tell you they've had 3 or 4 drinks, figure they've had 6 or 9 drinks, because they always cut it in half. Again, clean the wound, get them to the hospital. Not a lot you're going to be able to do for them. You will end up intubating and tubing and bagging these people if you wait too long or if they're too far away. So we do see these probably a little more so in May than now, but they're still out there. Jellyfish, man-o'-war, stingrays, lionfish. Of course, there's this move to, I guess, eradicate the lionfish from the local reefs. Sea urchins, anemones, fire coral, nematocysts. Those are those little things on the stingers that get into your tissue. You have local pain, redness, swelling. You can get lacerations from the stingrays. Systemic symptoms, again, nausea, vomiting, dyspnea, tachycardia, hypotension. Getting the patient to the hospital. Now, you know the different treatments for different types of stings. All right. So what do you use for the stingrays? Hot water. The hotter the better. Why do you use hot water? You understand why you use it? Because most of these stings have what's called heat labile proteins in their stingers or venoms. And what that means is that you can break them down and stop the pain and inflammation by putting it in hot water. It breaks the protein down. So that's why you use hot water. No, usually you need the hot water because it's more diffuse. You can try a heat pack if that's all you have. You can try that. If you can take the stinger out. You don't have to. If they come to the ER, we x-ray them if it's a stingray. These are just some examples here. This is just shows somebody stepping on the stingray, getting stung. There's one up there. It's a giant one, and a diver messing with it. I don't know why you'd want to do that. And I think this is supposed to be a stingray under here, and that's its eye. And that's a jellyfish. These are the nematocysts, those little things that are on their stingers that sting you and inject their venom into you. I think that's supposed to be a barb from a lionfish. Fire coral, another jellyfish man of war. That's one of those sea snails. We don't have the sea snake in here. I don't have a picture of a sea snake. It looks like a big green snake. They have poisonous venom too. Okay. So, what are some of the other things that we can use? Ammonia denatures some of the protein in jellyfish stings. Okay? What's the source of ammonia on the beach? Because you don't carry that in your trucks. You piss on it, yeah. Well, you don't have to piss on it. You can tell the patient, have your boyfriend, girlfriend, whoever piss on your foot, it'll make it feel better. So that's something you can use. Lion fish, usually you got to take the barb out. Just have them come to the ER because it's going to hurt like hell for you to pull it out. Now, if you're 50 miles off the coast on a reef, then it'd behoove you to try to get the barb out of there, the spike. It's a spike. Yeah, it's just a spike. But it's like anything, they hurt. They're very aggressive fish. Okay, let's take a break so I can change it to the other slides. So, one of the things you got to think about, and we always talk about the ends of the age spectrum, the very young, the very old. They're the ones that always have issues in terms of tolerance of what's happening in their life, in terms of their environment around them. So they're going to be more predisposed to a lot of issues, as we know from previous discussion, but especially with heat-related illnesses, whether it's hot or cold. Also, if a patient has chronic underlying diseases like diabetes, hypertension, coronary disease, they also will have problems managing their body's temperature regulation, and not so much because of the disease itself, but because of a lot of the medications they take, which inhibit their body's own mechanisms for handling those extremes in temperature. And of course, dehydration plays a role. So if you have a patient who's 75 on diuretics, and it's 95 degrees out with 98% humidity, what do you think their problem is going to be if they were sitting out in the heat for 2 or 3 hours? I mean, they're really going to be dry, okay, because of the combination of the diuretics as well as the heat and the sweating. So we know the body likes to maintain a temperature within a certain range. Your heat management comes from a portion of your brain called the hypothalamus, and that determines how you balance your heat supply in your body, how you get rid of it. You need heat to some extent for metabolism, and again, metabolism also generates heat. Now, generally 98.6 has been the standard, but there is a range for temperatures. So if you take somebody's temperature and it's 97.9, that doesn't mean that there's a problem with them. Okay, there are ranges, there are variations in people. But the temperatures at the bottom, hypothermia at 95 and heat stroke at 104, are fairly consistent. So keep that in mind if you say, well, why do I have to take a patient's temperature? Well, here's an example of why you need it. Okay. So, what is the best way to take a temperature? And there's been a lot of debate with this. We can't do rectal temperatures. okay? We do them in the hospital, but you can't do them pre-hospital. Now, if your patient you're going to see is in a nursing home, you can ask them to do it. I would not do axillary if you can avoid it. That's not the best way to do it. Those, as you see, those temperature changes can occur orally. If a patient's breathing by mouth, it's going to be cooler when you take their oral temp, okay? Or, and this is a trick school kids would do all the time, drink something hot just before you take the temperature, and it would make the temp go up, obviously. So those are some of the drawbacks with the various ways we do temperatures. The skin, again, those skin temp things, CBT is core body temperature, in case you didn't know that, can be influenced by the capillary refill, because that's what they actually look at. Here's a little joke. What's it say? Means of determining core temperature includes rectal and tympanic measurements. Your medical director will decide which to use. I don't get it, so like, whatever. So how does this thermal regulatory process work? You get signals from your thermoreceptors in the skin, muscles, the carotids, and it goes to the hypothalamus, which then changes your vasodilatation, vasoconstriction, shivering, and all the mechanisms that go into effect to eliminate heat or to generate heat. We said that your metabolism produces heat. Your BMR is the energy produced at rest from normal body functions, and I talk about BMRs a lot in the office with my patients who come in for consults on hormone replacement therapy, because BMR determines how they're going to burn their calories. Here's a general number, 70 kilogram persons to 70 kilocalories per hour. There is differences in age, stress, hormone evaluation, and what hormones are functional in them as well. Here's an interesting fact. Two people who weigh the same, the shorter one will have a higher BMR. None of this stuff is rocket science, guys. This is just basic stuff. Heat generated by metabolism and the glycogen breakdown warms the body. Excess is dissipated between the body and the outside environment. We'll talk about the ways we dissipate heat. If the temperature on the outside is higher, the body will absorb that outside heat if it needs it. We know skin is one of the ways we eliminate heat in our body. And we see 60% of cardiac output, 8 liters a minute, can help liberate that heat. So, some of the physiologic responses, core body temp causes vasodilatation and sweating, an increase in core body temp. And of course, what's that going to do? It's going to increase your volume, your heart output, and your pulse rate, and stroke volume, your volume of blood that you're pushing. So, this is more along the lines of what we're going to talk about in heat-managed illnesses. How do we get rid of excess heat? Now, this is also true in terms of absorbing it from the environment if our body's cold. But these are the 4 general mechanisms that we use. Radiation, and it's not exactly what it says up there. Radiation means radiant heat, which just basically comes off the body, and you can see that sometimes in cold weather. People that are sweating in football, if you watch the football teams, the guy takes off his helmet and you see this heat wave. Okay, that's radiant heat. Conduction is through direct physical contact, so he puts on a cold towel on his head to absorb that sweat. Convection, it's moving air or liquids. Again, another mechanism where it's the same thing, you're sweating and you're absorbing that sweat. You have 2 mechanisms in place. And evaporation, where the liquid gets converted to gas. Those are ways of eliminating heat. You don't need to know this. Yeah, we don't need to know that. Okay. So, risk factors for heat illness. Older patients, they perspire less. A lot of that's because of their age and also because of the meds they take. They, again, acclimatize more slowly. And we know that's true, again, because of their age and the medicines they take. Realize that the body's physiologic responses degenerate over time because of a degeneration of their hormones. so they don't have the same rapid ability to compensate. They don't feel thirsty as easily, especially if they've been on diuretics. They don't move around a lot, and they have a lot of chronic medical conditions, which is what contributes to this. Again, we mentioned diuretics, beta blockers, alpha blockers, which aren't listed in there, so there's a lot of other blockers that would apply to this, calcium channel blockers. In kids, either end of the age spectrum, they have a higher metabolic heat production because they're young, their metabolism runs at a faster rate. Their body temperature rises faster than in an older person, and their systems can't dissipate heat as well because they're generally smaller. Obviously, anybody that's doing anything out in the heat, military recruits, athletes, police, fire, you have an increased risk of suffering heat illness. And I see this with the SWAT team that I'm the medical director for when we go out and do our training in this kind of weather. Dehydration is a real possibility and can occur, especially with all the gear on. Same as for yourselves when you're out at a fire and all your bunker gear in this kind of heat, you need that recovery period. You need a period of time when you start getting too dry that you need to get out of that heat, cool down, increase your fluid volume. Sometimes you might need IVs. You should be able to take it all orally unless you're vomiting, but sometimes you may need an IV to help. So we had the general heading of heat illness. Now let's look at some particulars. Heat cramps, they're involuntary muscle spasms. They occur from sodium loss. So you see it in patients who are sweating profusely. They start cramping up. And you can see this on the football fields this time of year. At the football games, you'll see guys that develop heat cramps. Usually they're in good physical shape, so you see them with your firemen, your police, your athletes. We've all seen it. You have to have the physical activity. They may have pain, hypotension, and nausea. They may be tachycardic. They may have pale, wet skin, but their temperature is usually normal. You get them out of the heat source, wherever it happens to be, and you replenish their volume. As I said, if they're not vomiting, you can give them oral liquids. You don't necessarily have to give them Gatorade. Water's fine. There is a syndrome called SIADH, which comes from too much free water ingestion. Some of it is iatrogenic, meaning some patients are water drinkers. They drink gallons of water a day and they dilute their sodium. You can also do this inadvertently by giving too much in the way of IV fluids. So you want to be careful. As long as you give saline, you shouldn't have the problem. Free water would be a problem, like D5 in water would be a problem. Heat syncope would be your heat cramps, maybe, associated with passing out. Now, normally, this is going to be in somebody who is athletic or is physically in better shape, whereas this is normally from somebody who doesn't really have great physical conditioning, okay? And they can become orthostatic, meaning that they were sitting down, they've been in the heat, they go to stand up to walk to the car, and they faint. Couldn't be from prolonged standing where they've been watching the football game and they haven't been drinking, and again, it's a change in position. Lay them down, fluids. If they don't recover, then these are the ones we're going to talk about next. Heat stroke, heat exhaustion, cardiac syncope, and coronary syndromes. So what's heat exhaustion? Well, it's more than heat syncope. Okay, it's a milder form of a heat illness. You see volume depletion. What is the underlying theme so far? Volume depletion, remember that. These people need fluids. There's water depleted and sodium depleted. Now, are you going to do a set of electrolytes out there in the field? No, you're not. But remember what I said, if you take in too much fluid, you get what's called inappropriate secretion of antidiuretic hormone, and that's what they're talking about here. Exercise-associated hyponatremia, which is prolonged exertion with excessive fluid intake, and this is usually free water, meaning they're usually drinking way too much water, and they dilute their sodium. There's also a hormonal response. You don't have to worry about that because we're not going to correct the hormone. But look at these symptoms. Headache, fatigue, weakness, dizziness, nausea, vomiting. They may have belly cramps. They can be sweating and clammy skin. They may have a slight temperature, maybe tachycardic, could be orthostatic as well, and they might be hypotensive. Notice it's pretty much the same management, cool environment. Lay them down, elevate the legs, and then, of course, use tepid water, not ice water, tepid water so that you induce another form of cooling, that evaporative cooling. And you can hydrate them if they're not nauseated and vomiting with oral liquids. And the sports drinks have sugar and sodium in them. So those patients would need that salt. Now, when they come to the ER, we can do this. You're not going to do this in the field. You can use the IV normal saline, of course. But you're not going to be able to give them, check their sodium. So it's a clinical inference. Heat stroke. Now we're getting to something more significant. What are the pathognomonic is altered mental status and body temperature over 104. Those are the things you got to remember. There's classic heat stroke and exertional heat stroke. Remember we said altered mental status, so you have irritability, combativeness. They may be hallucinating, may be dry, dehydrated. Their skin will be dry, red, and hot. If it's classic heat stroke and they're talking about exertional heat stroke and somebody that's practicing football, they may have a little bit of sweaty skin but be pale. Mad as a beet, crazy as a hatter. No. Red as a beet, mad as a hatter, crazy as a loon. This came to my head. It's a random thought. What is that for? It's a poisoning syndrome that occurs with a drug that we don't use anymore, and now I can't remember the drug, so but it kept popping in my head while I was looking at this distracting me. What was that? No, it was a psych type of drug. Oh, the reason they said mad as a hatter and red as a beet is because it was associated with people that made hats. What did they use? They used nitrates, and did they use mercury to make hats? Because red as a beet is usually a nitrate poisoning. But I'm wondering, no, nitrate is methemoglobinemia. It's maybe a heavy metal they used in the old days when they made hats, because mad as a hatter comes from the profession of people that made hats used a certain chemical, and I can't remember the name of it now. Anyway, sorry about that. It was an anticholinergic. Now this thing pops up here, but I can't remember the name of the drug. Okay, so do you think if you saw somebody who was septic, they would look the same as somebody with heat stroke? And, this is a valid point. Think about this. You got somebody in a house, 80-year-old, lives by themselves, and neighbor comes over and finds them confused on their couch, hot to the touch, and she calls you, and you come out to the scene, and you see this 80-year-old who has a fever of 104, is hot, dry to the touch. How do you determine if that's going to be sepsis versus heat stroke? The heat's on in the house, and it's 90 degrees, plus the fact that it's 90 degrees outside. And this is an actual case. For your purposes, does it change your treatment? I mean, the reality of it is no, it doesn't. You're still going to do your ABCs, you're going to put a line in her, you're going to give her some fluids. So for your purposes, no, it doesn't really change the treatment. But that's something that you would have to think about. I think the problem